Just want to welcome you all here to Stormont tonight for the event, which has been entitled First Do No Harm. If you are on Twitter or Facebook, if you want to use the hashtag First Do No Harm, feel free to tweet out to Facebook messages and raise the profile of what we're going to hear about tonight. I just want to extend a very warm Northern Irish welcome to not just our keynote speaker, but all of the speakers tonight, but certainly those who have made the effort to travel perhaps thousands of miles, some hundreds of miles, and each and every one of you that are here tonight, whether you're a medical professional, whether you're a politician like myself or Paula there, and if there are any other MLAs here, hi. I only seen Paula, but certainly there's a couple of MLAs here. Special thanks to Joan McParland and her team for their relentless efforts, not only in supporting those living with ME or fibro, but for lobbying politicians like myself and professionals in advocating for some who have no voice and have been left with no voice for a number of years. I got involved with this group 2 short years ago when I first entered politics in Northern Ireland, and I've always wanted to offer my support and assistance to the group because I have a little personal story back home of where this has affected me at home. But it was very recently, a number of months ago, at the screening in Newry of the film Unrest, which really piqued my interest and opened my eyes into a world which, in terms of the numbers, I didn't know that it was hitting. So if you don't know what Unrest was, and I know tonight's not about Unrest, but I just want to offer you a little idea. Unrest charts the personal story of a lady called Jennifer Bray, a PhD student, who was struck down with a fever. And she was told by medical professionals that it was all in her head. She takes her camera, she turns the camera on herself, and she does a little personal biography or documentary, if you like. And what I took out of the film most, perhaps, was that she was able to tap into the rest of the world. And that became known, I believe, as Missing Millions. It was a global community of sufferers that have been badly let down by professionals, including politicians like myself, but who through peer support have sought and fought for recognition and understanding and a voice to turn their tide, ease the burden on their families and their carers that are helping them navigate their world. So if you haven't seen the film, please look out for it. So that's me done. Gives me great pleasure now to take my seat and introduce you to, I was going to say, the head honcho and her able cast from Hope4ME and Fibro. Thank you.
Good evening and welcome to Hope4ME and Fibro Northern Ireland Annual Conference. My name is Joan McParland, founder and coordinator of this patient-led charity. And we have been bringing world-leading ME and fibromyalgia experts to Northern Ireland since 2011. We are absolutely overwhelmed by the high numbers of medical professionals who have booked places this year. It's taken 7 years of very, very hard work to get to this stage. We actually sold out and people were booking this morning. We deeply appreciate your efforts to attend, especially after an already hard day's work. So I have 5 minutes to explain who we are, what we do and why we do it. A wee bit of why we do it. Our charity has 7 committee members only who live all around Northern Ireland, made up of 5 patients and 2 healthy volunteers who have family members with ME. We do not have any paid staff. I work from my sickbed as I cannot tolerate being upright for more than a couple of hours at a time. I do this because after about 10 years with this disease, I realised that nobody's coming to rescue me. I am now 19 years from sudden onset ME in October 1999, and I must add I have never felt fatigued, tired or depressed, but I have felt frustrated, frightened and poisoned, and desperate for relief of the multitude of symptoms. There are 7,000 ME patients in Northern Ireland, and our campaign is about giving them a voice. Immediately after my presentation, we will be giving a voice to hundreds more patients, thanks to a gentleman called Robert, I haven't got a surname, it'll be up anyway, who organised a very emotional 4 minutes of information. Next one please. This is our charity headquarters. You may well laugh, but it's not very plush. It's more than adequate and functional for our needs because it's right beside my mum's house, who lives right beside me. So it's easy accessed. Patients donated all the office furniture, the heaters, even down to the carpet. So without our fundraisers, we simply wouldn't survive. Next one here, please. And so meet some of the amazing people who make our work possible, as we do not receive any core funding and rely on their generosity and small funding grants when available. Our healthy fundraisers organise sponsored book reads, cake sales, etc. And we gather up old clothes for a Cash for Clobber scheme. Next one, please. We run 3 Facebook pages, the announcements page just for advertising events, a closed patient chat page, and the committee organising page. We use Facebook very constructively to help address the isolation of our bedbound and housebound members. We also live stream our monthly meeting speakers out to our sickest members who are dotted all over Northern Ireland. We have some other wonderful people on board who help and support the charity. We'll just go quickly around these, right? The Countess of Mar, a patron, an ME patient. Dr. Anne McIntyre, author of the book Managing ME, another patient. Dr. Nigel Spate, our paediatric expert. Our medical advisor, Dr. Weir, who travels from London every few months to see desperate patients in Northern Ireland, who at present have nowhere else to turn. Dr. Vance Spence, founder of ME Research UK, another patient. We are members of the European ME Alliance and members of the Confederation of Community Groups in County Down, and the charity was awarded the Patricia Graham Shining Light Award for voluntary services to the community in 2013. We support the Missing Millions campaign, a global movement started by Jane Brea in America to raise awareness in cities and towns all over the world on designated days. That was us at Stormont. Here is a list of the countries who took part in this year's growing movement. Europe, UK, Mexico, United States, Canada, and our wee army in Northern Ireland did Belfast, Newry, Banbridge and Armagh and Craigavon, which I think was brilliant. We also have a special message from just one of our very severely affected members. She asks, missing 12 years from normal life, please fund biomedical research. Thank you. This patient's health plummeted into this state, completely bedbound, after taking part in an exercise programme. She has been 12 years in bed ever since, and this is just one of the many heartbreaking stories we hear every day. Next one, please. We screened an educational documentary called Unrest in Newry this year. The film was also produced by Jane Brea, who tells about her life with ME, plus some of the politics surrounding the disease, and our fight from our beds for adequate health care. Next one, please. We also screened Unrest to over 300 medical students in Queen's University this May, thanks to the help from ME patient Dr. Olivia Beattie. And many filled in our questionnaire after watching the film. The overall theme of the questionnaire replies are asking for more information and for the disease to be covered in the medical curriculum. According to a Freedom of Information request we put in a few years ago, the Northern Ireland Medical and Dental Training Agency, ME, is not covered as yet. The questionnaire results are available to anyone tonight who is interested. Just contact the charity, please, and I'll forward the document. Please note, our charity will provide a free screening of Unrest for any group of medical professionals, any hospital or any GP surgery in Northern Ireland. We can do this because we have volunteers dotted all around the place. And we can also provide information packs similar to what you have tonight at a non-profit minimal cost. Next one, please. These are patients at our monthly meetings who were designated one night to filling the info packs, and we got 500 done in one night. So our monthly meetings certainly aren't a moaning session. Next one, please. So our future events this year include the following. In November, we have a wonderful opportunity for education again, thanks to Dr. Robin Higgin, yet another UK doctor with ME who contacted us. We are funding a lecture on ME provided by our medical advisor, Dr. Weir, to 150 registrars in Manchester Royal Infirmary. Robin has produced a book on ME, you see here on the right. Believe it or not, this morning before I left, I received an email asking if hospital governors could attend. I think that really says it all. Next one, please. In November, we are delighted Dr. David Tuller, a Senior Fellow in Public Health and Journalism in Berkeley University, is coming to Newry to provide a lecture on the PACE trial on the 2nd of October. So a date for your diary if you'd like to now learn more about the now infamous PACE trial from the world's expert. Please come along. There is a flyer in your information folder. You may not be aware there was a recent 3-hour ME debate in Westminster Hall. And if interested, the entire proceedings are on Hanson. I think I have the thing there. And on YouTube, you can see the whole procedure. Carolyn Monaghan, SNP, rightly described the current ME situation as the greatest medical scandal of this century. Next one, please. Indeed, the PACE trial has now been used as an example of how not to run clinical trials in 2 universities in America, Berkeley and Columbia. Psychology in Crisis book has a whole chapter dedicated to the faults of the PACE trial, and the Journal of Health Psychology dedicated a whole special issue to the trial and its shortcomings. It is very hopeful to see science writers and universities highlighting the whole sorry tale, so it's not just patients reporting the harms caused by trying to exorcise ME patients out of an incurable neurological disease. And next one, please. So more good news. Dr. McBride, this gentleman asked me to let you know this. He's back. Dr. Jonathan Kerr, Belfast-born and Queen's University educated researcher, is back working in the UK. And we got an email from him about 3 weeks ago saying he would love to launch his new research paper in Northern Ireland. So we're doing that in November as well, Tuesday the 6th, I think. So, right, one more. The other services we offer, we are sole distributors in Northern Ireland for the Canadian Consensus Crisis for fibromyalgia and ME, and also the International Consensus Primer for ME. This booklet was compiled by 28 experts from around the world. We have included a free copy in your folder, and extra copies are available at the information stands. The charity supports patients with both ME and fibromyalgia due to the overlap of symptoms and the enormously high rates of misdiagnosis in the UK, reported by research from Professor Julian Newton in Newcastle University. And on a personal note, I must add, I get emails and phone calls from nurses in mental health departments in Northern Ireland asking for information packs to learn how to help ME patients, as these nurses clearly recognise they're not mentally ill, but unfortunately this is where they end up. But hopefully this will resolve if we get proper specialist services. The situation with the current NICE guidelines for whatever CFSME is, the director of NICE, Professor Mark Baker, is recorded as stating in his own words, is not fit for purpose. Thankfully, these guidelines are now under review, but that review will not be completed until 2020. So the advice to doctors to recommend GET and CBT remains in Northern Ireland. The PACE controversy is causing uproar within medical and research circles around the world and departments of health. So much so that the HSE in Ireland has removed GET and CBT from their website, thanks to the ME Advocates Ireland group campaign. You're here today. Plus, the New York Department of Health issued cautionary instructions about advising exercise to ME patients to 85,000 doctors. In May last year at our conference, charity trustees were given a firm assurance from the HSCB that Northern Ireland medical professionals would be issued with a similar caution. Unfortunately, we waited 7 months only to be told the HSCB do not have the authority to do so. We live in hope. And lastly, we are stakeholders in this lengthy review process. These are 2 of our representatives, Sally Birch and Andy Hugh, are pictured here with Professor Barker at a recent stakeholder meeting. So I'd finally like to thank the sponsors of tonight's event, the 2 patients who covered the numbers of free tickets for professionals, the Irish ME Association in Dublin for part funding the video recording, and the HSC Research and Development Division for part funding some of our costs as well. That was a very last minute thing, so we're very grateful to that. Please note the question and answer session will not be included in the DVD, so feel free to speak freely. Doesn't make sense. We will have the DVDs on sale shortly, so feel free to look up our website or our Facebook announcements page to keep up with events. And I'm just taking this opportunity. We seriously need a volunteer to look after that website, because I don't know how to work websites, and neither do any of the committee now. Right after this here, as I said, our charity focuses on giving a voice to patients. So we who call ourselves the Walking Wounded dedicate the next few minutes, Richard, all right? Dedicate the next few minutes to the very severely affected patients and to the children. We know after tonight, every ME patient that you here tonight encounter will be met with compassion and receive the greatest gift in all of hearing the words, "I believe you." And I will support you through this difficult journey. Thank you for listening.
Joan mentioned the NICE clinical guidelines, and I want to address that up front and very directly. As you know, NICE is conducting a review of the clinical guidance on the diagnosis and management of ME and chronic fatigue syndrome, CG53. Last updated in 2007, and it's quite clear things have moved on since that time, and it's hugely important that those health professionals in the front line are informed in their clinical practice by the best available evidence. Unfortunately, such is the nature of those reviews that it's not due to conclude to 2020. But there will be, as there is, always a full consultation on the draft guidance before it is finalised. And I'm absolutely confident that those living with the condition, those lobbying and representing you will have their say in contributing to that, and that's how it should be. I suppose there's but one thing I want to highlight in the guidance, and I suppose I really want to reflect ME, chronic fatigue syndrome, in the context of the changes that we're seeking to implement in health and social care services here in Northern Ireland. CG53 is important in one respect, in that it recommends shared decision making between the patient using the service, the healthcare professional, and it recommends supportive and collaborative relationships. Now, that might not be your experience of how that has translated into a given effect, but that is a fundamental commitment within that clinical guidance, and that individualisation and tailored treatment to the needs of an individual are crucially important. And this broadly reflects the ambition outlined in the Department of Health's strategic paper, Health and Wellbeing 2026, or as we more commonly know it, Delivering Together, for a new model of truly patient-centred care, focused on prevention, early intervention, supporting independence and well-being. And I suppose that's the one thing that struck me in Joan's opening comments. She wasn't waiting for someone to come and rescue her, but what she was wanting was someone to listen to her and to meet the needs that she might rightly expect. Health and Wellbeing 2026, Delivering Together, identified a number of challenges facing health and social care in Northern Ireland. We didn't invent those challenges. They're not unique to health economies, similar to health economies around the world, and they're familiar to most of us. The positive aspects of an ageing population, which is a really good thing and a sign of our success as public sector, as public services and across government, but also with that the increasing prevalence of long-term conditions, with people often living with multiple comorbidities, and rightly increasing expectations about how health and social care should be delivered. That, combined with a squeeze on resources, both financial resources and workforce pressures, and the bureaucracy and systems of health and social care organisational structure and delivery, which were not always supportive of the need to move at pace to effect the change that we need. So we create bureaucracies and organisational system constructs which often get in the way of us doing at pace what we know needs to be done. Now, as Delivering Together concluded, in the face of these challenges, it's not sustainable simply to continue to do what we've always done. We cannot just provide services, we must transform them and make health and social care in Northern Ireland fit for the 21st century. And as you'll be aware, we have a challenging programme of transformation and reform, which I think has a real chance of fundamentally making a difference to the lives of our citizens, both at a population level but also as individuals. For most people living with ME or chronic fatigue syndrome, the primary care team is central to supporting them to manage their condition. A key aspect of Delivering Together is a new model for primary care based on multidisciplinary teams embedded around general practice with a focus on the physical, mental health, social well-being of the population, and a stronger emphasis, I've said, on prevention, early intervention. And to achieve the vision of that transformed primary care service would require a move away from a system that is currently based on GPs working largely independently, hugely committed, hugely pressurised, but it will in future involve the input from other disciplines to create a genuinely multi-professional form of working. Now, this new and innovative approach is how care is to be designed and delivered, and it has been informed and driven by engagement and partnership working with a wide range of stakeholders. And I believe its real benefits and better outcomes will be for people living with long-term conditions, including those living with ME and chronic fatigue syndrome. Now, that new model, that new approach has already started. It started back in 2015 with the rollout of practice-based pharmacists across Northern Ireland as an integrated part of the GP practice teams to support GPs, making best use of medicines and outcomes for patients as a consequence. And as anticipated, by 2021 there'll be over 300 practice-based pharmacists in posts. We also have work underway that will see the establishment of those multidisciplinary teams that I've referred to. That will include practice-based physiotherapists, social workers, mental health practitioners, as well as in putting in place additional support for data analytics and improvements to the primary secondary care interface, where so often it can feel like a nightmare negotiating one's way through that. And as you will have heard, at the start of September, we announced that GP federations in Down and Derry, Londonderry, will be the first to benefit from this new multidisciplinary team model, a test of the concept. But certainly I would hope that in future we will see other members of specialist what are traditionally in secondary care working in an integrated way so that they are more accessible to you in a primary care setting. It'll allow us to deliver more treatment closer to people's homes, reduce the need for referrals and appointments elsewhere. But importantly, it'll also enable health and social care professionals to support the whole person, holistic approach to how we deliver care, and help us understand how living with a long-term condition can often impact on many aspects of life beyond the physical, and will enable us to better respond to this with services that are wrapped around the individual and delivered with a more cohesive and coordinated primary care sector, able to engage with the most appropriate members of the multidisciplinary team to meet their needs. Now, to do all of this, we need to work in partnership. We need to work in partnership with people living with long-term conditions. We have a commitment within Delivering Together to co-production, which is about designing those service models to best meet those needs, working with those who use those services, working alongside those who deliver those services. And I think that will provide a tremendous opportunity, and examples such as social prescribing, community pharmacy to promote well-being and early intervention. I think in this way, people, us that use health services, can be supported of the knowledge and skills that we all need to manage our own conditions more confidently and to maintain or enhance our sense of well-being and health. There's nothing more disempowering than feeling not supported in managing or taking control over your own condition. Even made worse when you get a sense that others don't believe that you have a condition, or the condition that you've been diagnosed with doesn't exist. No one as a patient should feel the need to fight for recognition of their condition. That was ever the case, and that you and those that you represent have made to feel that way is a matter of huge regret to me. In addition to these developments in primary care, general practitioners have an important role in managing that interface between the rest of the health service. And many of you this evening will be familiar with the range of health and social care interventions currently provided to help improve access to service with patients who have a neuromuscular condition and their families and carers. And I've just talking to some of the speakers today. We have a lot of ground to make up in Northern Ireland in terms of what at times feels a patchy and fragmented service. But we do have nurse-led neuromuscular clinics across Northern Ireland which provide advice and support on how and where to access services, including physiotherapy and psychology, as well as other services. Additionally, in the Northern and Belfast Trusts, they provide condition management programs for adults with a confirmed diagnosis of chronic fatigue syndrome or ME. Again, the individuals referred being managed by a dedicated health professionals in the field. And for non-clinical support, we have the Northern Ireland Neurological Care Advice Service for information, advice and support for adults with living with a neurological condition. And it serves people right across the province with friendly, free and confidential advice. Those are just some examples of service provision innovation. In the interest of time, I'm cutting through a lot of this because I know we have time to make up. But I just wanted to acknowledge, as Chief Medical Officer, that provision is variable between trusts. It's patchy in places, and it needs to be improved. And in order to address this, the department is supporting the appointment of a regional clinical lead for ME and CFS. Equity of service and access to service for patients across Northern Ireland, the education and training of community, primary and secondary care staff will be facilitated by this development, and the recruitment process is currently underway with Health and Social Care Board colleagues in the lead. I suppose as closing, as Chief Medical Officer, the guiding principle for me is undoubtedly, as it is for all of us working in health and social care, is to protect and improve the quality of our services and as a consequence improve the health and well-being of the population we serve. It is undoubtedly the case that in this area we have significant improvement to make. I'm here this evening to listen and to learn for those much more expert in the field than I, but also those of you who have the lived experience of living with chronic fatigue syndrome, fibromyalgia, or indeed ME or whatever. I wanted to thank you, those who have taken the opportunity to share with me their personal stories and experiences with the health service in Northern Ireland here this evening at today's event. But I also wanted to thank you who have taken the time over the years to write to me and express your concerns and reservations about the current level of care provision, or indeed the current guidance that's available to health professionals here. I think this is an important step forward, and again just thank Robbie for sponsoring the event and for all your attendance. And the closing remark, it must be fate, but you mentioned Jonathan Kerr. Jonathan Kerr and Dr. Olivia Beattie were both in my year of Queen's in medicine. They're both much smarter than I am, much smarter. I won't dispute that, sure, I won't dispute that. I led with my chin in that one, didn't I? But as I say, two more committed, experienced clinicians I've never come across, and I'm delighted that they're lending their support and their expertise and knowledge to supporting your cause. So thank you. Thank you.
Okay, good evening, I should say. I'm Louise Skelly, and I have my friend and colleague, Dr.
Pamela Bell.
Yeah. And we are doing a double act tonight, as you can see. I'm head of operations for the Patient and Client Council, and for those of you who don't know, we are the statutory body working in health and social care to represent the voice of patients and service users. And we have a number of statutory functions which enable us to do that. However, tonight we're looking at the subject of ME, and Dr. McBride has talked about the importance of the guidance in terms of partnership working. And 5 or perhaps 6 years ago, Pamela, when we began this journey, I would have to say there was very little partnership working around the subject of ME. And one of the strengths, I think, of the Patient and Client Council has been providing a voice to those who haven't had a voice. ME patients were being heard, but I don't think they were being seriously listened to 5 or 6 years ago. And I have to say that where we are standing here tonight, I'm sure, Pamela, you would perhaps agree with me, that landscape has changed in the 5 years. It does take a long time to effect change, and Dr. McBride has talked about the huge bureaucratic system that we have to work our way through. And day and daily within the Patient and Client Council, we run across that. And we realise that it takes tenacity, stickability, and just not going away to actually effect some changes. But there's been a lot of talk about all of the changes that are happening with Transforming Your Care. And there's a lot of talk about co-production, which is this nice new guide which has been launched by the department. But co-production is quite simply partnership working. Everybody working around the table together. And I think I take my hat off to the ME patients who, in the midst of their illness over the last 5 years, have worked in genuine partnership with the Patient and Client Council, with the staff in the commissioning board, with the Public Health Agency, with our voluntary and community sector colleagues, including Dr. Bell and the Pain Alliance in Northern Ireland. And we've done lots of different things throughout that journey. I remember Joan in Newry earlier in the year reminded me that I said to her when I first started working with her, Joan, it takes 3 years to get through this system. And you said to me, now Louise, it's 5 years. And so it has taken longer than we thought. But we are delighted to say that things have started to move. We co-produced a paper together, which was a position statement. If anybody wants to read that, that's on our website, which summarises the journey we've been on and where we got together. And that was really helpful in terms of engaging with decision makers at all levels, because the Patient and Client Council is an evidence-based organisation, and our evidence comes from the patients at the end of the day, the people in this room who have the lived experience, but also know that they're working with a large bureaucratic system, and it takes time to navigate that. And that's where we have found it really helpful to work with the patients, and we help you navigate that system. And tomorrow, the interviews are being held for the lead clinician. So I am absolutely delighted. Tomorrow, yes, tomorrow. Wow. So I am absolutely delighted to. I perhaps shouldn't have bust your bubble, Pamela.
You did. Never mind.
But you can tell us more about. But we have been on a journey learning about ME patients' experiences, but also learning about the science, which Pamela knows much more about than me. So I'll hand over to you, Pamela.
Well, I certainly don't claim to be an expert in the science of ME. I think the only thing I would hold my hat up for is that I know how to conduct a good research study. And over the years of doing research in one form or another, my recent research has been in Scotland rather than Northern Ireland. I know how to make a good study, and I know how to recognise when a study is weak. I've been, for those of you who don't know my background was largely in anaesthesia and pain medicine. And when it comes to things like the NICE guidance, I'm afraid that ME has not been alone in suffering from the development of guidance that has been based on relatively poor research evidence. Certainly our back pain guidance, the original NICE back pain guidance, was flawed by the fact that it was not based on very robust evidence, and that has since been reviewed, and the current guidelines are much better, much more usable, much more relevant to patients, but also things that GPs and other specialists can deliver on. So I'm hoping the same will eventually happen with ME. There's certainly much more evidence out there that it is based in disruption or dysfunction typical psychiatric disease. So that said, and having been going on this journey with Louise, I'm delighted to tell you that tomorrow afternoon we will be holding the long-awaited interviews for a specialist in ME for Northern Ireland, someone who will lead a service. Yes, Dr. McBride has elucidated what is already available out there in Northern Ireland, but it is not necessarily so easily accessed, not so well coordinated, and requires leadership. So I'm hoping that this appointee will take on that leadership role, will take on a coordination role, will advocate for patients, will support general practitioners, allied health professionals, consultants in other fields, to ensure that those who present with fatigue, with pain, with all the multitude of symptoms that cluster around in ME, that they will be there to help unpick that. Because I've always felt it's as dangerous, if you like, to be diagnosed with something that you don't have, as to be for the diagnosis to be missed. So, not all fatigue is ME, and a little leadership around helping with diagnosis, even before we move on to debating about how it should be managed, will be a very great thing. So I hope by tomorrow evening we will be in a position to say that we have been able to offer the post to someone. And there'd be a temptation to step aside at this point in time, but I think both Louise and I will be keeping a little watching brief on what happens and goes on forward.
And I think it would be remiss of you and I not to mention Christina, because she's not here tonight.
Christina isn't here.
And leadership comes at all levels within health, and when you find someone who gives you that spark, you cling on to them, don't you, Pamela?
Absolutely.
And so I think Dr. Christina McMaster in the Patient and Client Council has been a wonderful person to work with over the last couple of years.
Yes, I think she's now health board, isn't she?
Is she the health board? I don't know. It's all the one now anyway. So anyway, that's a new announcement. So yes, so she's there in the middle somewhere, and she certainly has been a wonderful person to work with on the chronic pain journey and fibromyalgia as well. But also she's been hugely supportive of this particular cause as well. And we're very grateful to her as well for working with us on that journey. So she's not here tonight, but good to mention her.
Yeah, absolutely.
Yeah. Okay.
So thank you all.
Well, ladies and gentlemen, it's really a great privilege to be invited to an occasion like this, and I'd like to thank Hope4ME and Joan McParland in particular for honouring me in asking me along to talk to you. Now, my introduction to ME was about 30 years ago when I first met this man, Melvin Ramsey, who was my professional godfather, if you like, and grandfather, because I succeeded the man who succeeded him in his consultant position at the Royal Free Hospital. And Melvin Ramsey was the first to coin the term ME, myalgic encephalomyelitis, when he described the outbreak of this condition at the Royal Free Hospital in 1955. And I had the pleasure of many a conversation with Melvin Ramsey about ME, and he left me in no doubt whatsoever that this was an organic condition with absolutely no psychiatric dimension at all. And this is one of the issues that I'd like to discuss in reasonable depth tonight, that of this extraordinary fault line which runs through the medical profession even now, on the one side of which are doctors who think that this is a psychiatric condition, on the other side of which are doctors like myself who think that it has an organic basis. In fact, I don't think it has an organic basis. I know it has an organic basis because the scientific evidence in favour of organic disease is now very compelling. So, to start with, this is probably the best piece of evidence that's emerged in recent years to indicate that ME has a definite organic basis and that there's no psychological dimension to it at all. What you see here is a bicycle ergometer, and it's basically equipped to measure the amount of power being delivered through those pedals by the man doing the cycling. And secondly, you can see that he's wearing an oxygen mask. So as he pedals, his oxygen consumption is being measured. And if you measure the amount of energy being delivered through those pedals after instructing him to pedal to the point of exhaustion, you get a graph somewhat like that. And this will be the energy he's delivering through the pedals until he gets exhausted. And the oxygen he requires to do that will roughly parallel that. And there will come a point where, at the point of exhaustion, when he's exercising at peak capacity, his muscles will recognize that the delivery of oxygen to his muscles has reached a peak and can't actually be delivered at a greater rate. And the muscles recognize this, and there's a sort of short burst mechanism which enables the muscles to switch metabolic pathway from using oxygen to not using oxygen. Now, this is a very short burst mechanism which doesn't last long. And you'll see the likes of Mo Farah and company when they do their 10,000 meters, putting in a short burst right at the end of their race. And they will be switching to the anaerobic pathway when they do that. But because it's short burst and doesn't last long, they can't do that for the whole race. Now, I've represented the anaerobic threshold where energy delivery through the pedals and oxygen delivery through the heart and the lungs and circulation plateaus, and that is known as the anaerobic threshold. Now, if you take an unfit person who has been deliberately sedentary for about 6 weeks or more, and this is work which has been done at the Workwell Foundation in California, and you measure his anaerobic threshold, you'll find that it'll be way down here. And if you also do that for an ME patient who is ambulant and only moderately affected, you might find that their anaerobic threshold will be about the same level. However, the difference comes if you then put the unfit but healthy person on the bike again the next day, and his anaerobic threshold will be up here. In other words, he's got a bit fitter as a result of the exercise he's taken. And if he does that the next day and the next day, his anaerobic threshold will go up and up. Now, here lies the difference between an unfit, deconditioned, sedentary person who's otherwise healthy with no identifiable illness. Because the ME patient, if you do their anaerobic threshold the following day, on day 2, it'll be down there. And this resonates perfectly with one of the symptoms of ME, which I'll be coming on to next, so I'll cover that later. But here is a perfect example of one of the pieces of scientific work which has shown that ME has got nothing to do with a disordered psyche and everything to do with a disordered metabolic process due to some as yet unknown pathological process. So, how to diagnose ME? One of my most revered bosses when I was a houseman told me that every patient is like a book, and in order to actually understand the book and the patient, you've got to start at the beginning. In other words, start at the first chapter. And if there's a prologue, you actually go for the prologue before you even open the first page. And it's prologues which matter particularly with ME patients, because I like to see ME patients and ask them, first of all, what life was like before they got ill. And very frequently you get a story of a very fulfilling lifestyle. They're very active, sometimes even hyperactive. And I can see Joan blushing in the front row there because she was just such a person. And so we have people who really do seem to have this very fulfilling, very active lifestyle, and then suddenly their health falls off a cliff. Now, this doesn't always happen. I get some people whose illness has developed over a period of several months, and they've had a succession of virus infections of various kinds, and I regard them as slippery slope patients. It's as if their health has gradually deteriorated, as opposed to the other 50% who I regard as watershed patients. It's as if literally overnight they get ill with this problem. So, then I ask them to really, in their own words, discuss and tell me what it is that most affects their lifestyle. And the hallmark symptom is always fatigue, hardly ever anything else. And fatigue is nearly always physical, sometimes mental as well. And the other hallmark is that this fatigue is beyond what they've previously experienced, and it's always unrelieved by sleep. Sleep just does not seem to make a difference. Many people will say, well, I can have a good night's sleep, but I wake up feeling totally unrefreshed and even worse than when I felt the night before. The other feature, which again is a hallmark, it's a sine qua non, is post-exertional malaise, which is frequently delayed by a day or two and is reflected perfectly by that study with the bicycle ergometer I've just explained. Then you have people who say, I have brain fog. And the more technical term for brain fog is cognitive difficulties, in which frequently the short-term memory is very impaired, and they have an impairment of mental focus. They find themselves being very absent-minded, and when they're trying to follow the plot, say on a television soap, after 5 minutes they lose the plot because they don't quite remember what happened 2 or 3 minutes previously. So short-term memory is a real problem here. Musculoskeletal pain is often present, but not always. Sometimes this musculoskeletal pain is absolutely excruciating and resistant to conventional analgesics. In such a case, some patients get labelled with a slightly different diagnosis, fibromyalgia. But I personally think that fibromyalgia is a subcategory of ME and is not a different distinguishable disorder at all. It's in so many other respects, it's so similar to ME. It's, I think, simply a subcategory with one of the symptoms, i.e. muscle pain, much more prominent. Now, there are one or two other features which are not always present. Persistent so-called new headache, a headache which is not previously experienced by the patient. Sometimes this has a sort of migrainous aspect. Dysfunctional temperature control, refraction problems at the optician. These are people who think that they need glasses, so they go to the optician tries to refract them to discover what strength of lens they need, and have great difficulty doing so because what's happening is their accommodation reflex is very dysfunctional, and it seems to really slide to and fro when they're trying to focus on the figures the optician is is putting up in front of them, and it's a very characteristic feature. Some patients will come to me in desperation and say, look, I've been trying to get some reading glasses, but my optician says that they can't determine what strength of lens to give me because I have this problem of focusing. The other really quite common problem is an intolerance of normal environmental noise and light. And this, in its most severe form, sometimes results in patients staying in their bedroom with the curtains drawn day in and day out, and really suffering as a result of perfectly normal environmental stimuli from ordinary environmental noises and light. And precisely what the cause of this is, I don't know, but nonetheless, with my background in infectious diseases, I've seen plenty of people with acute meningitis, and this symptom of intolerance of light and noise is very similar to what one sees in someone with an acute meningitis. So maybe the pathophysiological explanation is the same. Of course, when you see a patient with presenting with fatigue and all these other features, you have to think of other possibilities. And of the chronic infections I've seen turn up in this context, there's HIV infection, of course, hepatitis B and or hepatitis C, Lyme disease. There are various endocrine conditions such as hypothyroidism, Addison's disease, and then malignant disease. I've seen someone who was presenting with the early stages of lymphoma, and I thought they had ME to start with, but then discovered a few enlarged lymph nodes, and on biopsy those lymph nodes proved to be malignant. There are various other items that you must think about, and on only one occasion have I made the diagnosis, but I saw a lady who kept telling me that her house was bad for her, particularly in the winter months. And she said that she always felt better when she got out of the house, and when she went back to the house, she always felt a bit groggy and drowsy. And some of her relatives began to complain of feeling groggy and drowsy in the house. And this was low-grade carbon monoxide exposure. And the problem was fixed when she got a plumber in to look at her boiler, which had been recently upgraded, and that's a common story. Then, of course, in someone with a very large BMI, sleep apnea has to be considered. Interestingly, I've seen sleep apnea diagnosed in ME patients who don't necessarily have the characteristic appearance of someone with sleep apnea. They're not necessarily enormously obese, and it's not obstructive sleep apnea. The sleep apnea they have is clearly some form of dysregulation of their nighttime breathing, which results in CO2 retention. And that dysregulation of nighttime breathing is probably part and parcel of an overall autonomic dysfunction, of which more later. The other thing to say is that all the standard investigations are frequently normal in such patients, and that puts them at risk of being told that they're malingering by unthinking and unknowing members of the medical profession who don't know much about this condition and who really ought to know better. Now, there are two particular complications of ME that I want to draw your attention to. The first is POTS, which is an acronym for postural orthostatic tachycardia syndrome. And probably the main physiological contributors to this condition in ME patients is a reduced plasma volume due to a reduction in circulating steroid, and also dysfunctional baroreceptors preventing the appropriate reflexes from operating when someone changes posture from lying down to standing up. What happens with POTS is that you get a reduction in blood flow back from the legs, and that reduction in blood flow is exacerbated by this reduction in plasma volume and the absence of those characteristic baroreceptor reflexes which contract the veins in your legs. And so you get a reduction in flow back to the heart. The heart has less blood to pump out, and you feel dizzy when you stand up. and the heart responds by accelerating, but even so that doesn't necessarily work because you still get a reduction in cardiac output. The other condition which I want really to draw your attention to, and which has only really sort of come to my notice in the last year or so, is mast cell activation disorder. It can present with a number of rather disparate clinical disorders. It can present sometimes with classical asthma, occasionally allergic types of eczema, and occasionally with anaphylaxis. Now, I have seen now 4 patients whose mast cell activation disorder has presented with very severe food intolerance. And without exception, all 4 of those patients with their food intolerance, being unable to eat anything, had lost enormous amounts of weight. And because of the psychological paradigm being predominant in their particular hospital, and with the consultants who were looking after them, they were initially labelled with the diagnosis of eating disorder or anorexia nervosa. Now, I will show you one of these patients. If you look closely at this young lady, she's about 5'8", but she weighs 47 kilograms in this picture. And her mother actually phoned me and said, look, she heard on the grapevine that I had an interest in ME and also in mast cell activation disorder. And she'd done her own reading on the internet and decided that her daughter had mast cell activation disorder. And so I went to see her, and I'm afraid to say I had difficulty with the medical profession looking after her in the hospital where she was a patient. If you look closely at her the right chest area, she's actually got a central venous line in place, and she was about to be given total parenteral nutrition. If you look at her jawline, she's rather bony. If you look at her collarbone on the left in particular, it's very well defined, and she's got rather bony shoulder. Now, I thought, yes, she's probably got mast cell activation disorder, and an eating disorder was an inappropriate diagnosis. And we eventually persuaded the hospital doctors looking after her that she needed to be treated for mast cell activation disorder. And the first thing we did was give her some intravenous ranitidine, which has antihistamine properties. And it worked miraculously. Within 24 hours, she's able to tolerate normal amounts of nutrition by mouth. And the nutrition initially was elemental, the sort of elemental oral nutrition you give to patients with gut problems. And anyway, to cut a long story short, this picture was taken in June, and when she was 47 kilograms. She continued on the ranitidine, and this picture was taken 2 weeks ago when she was 65 kilograms and doing well still on the ranitidine. And so this was a problem which I began to recognise was more widespread in the NHS, and there are actually 3 other girls in this similar situation, and one of them in particular I almost had a sort of professional bust-up with over the issue of whether or not they should receive treatment for mast cell activation disorder, because, well, suffice to say that this lot looking after this girl I refer to are still adhering to NICE guidelines, and they want to get her out of bed and give her graded exercise and cognitive behavioural therapy in the hope that her appetite will improve and she will start putting on weight. But she won't, because she's got mast cell activation disorder. Right. Just to go on to POTS. POTS is so severe in some patients that standing upright causes very severe syncopal symptoms due to reduced cardiac output. And the majority of patients characteristically find relative comfort only by lying horizontal. And the treatment is directed firstly to trying to expand the plasma volume with fludrocortisone, which is a mineralocorticoid steroid drug. You can try and supplement their sodium intake by giving them slow sodium. You can give them compression stockings. The beta blockers are useful to try and reduce the tachycardia, but I'm a bit, a lot of cardiologists do this for POTS, but I tend to argue that the reason they're tachycardic is that the blood flow back to the right side of the heart is so reduced, the heart is actually responding physiologically, and giving beta blockers is simply opposing a natural physiological reflex. Some patients are so badly hit with this that they have a permanent central venous line, and they get up in the morning and have a litre of normal saline to get them going, and that's fed in over an hour or so. Finally, there is some evidence that pyridostigmine also has a beneficial effect on what is called preload cardiac failure. In other words, actually, in some way or other, enhances the baroreceptor reflexes that that these patients seem to lack. Right. There are a few vital points to take away. In my view, early recognition of this horrible disease is absolutely imperative. And the GPs are on the front line in this respect, and they should probably start suspecting the diagnosis when fatigue and general malaise, particularly malaise that is induced by exercise, lasts for more than 6 weeks after a virus infection. And the last thing you should do for such a patient is to advise him or her to go and exercise their way back to fitness in the gym. The appropriate treatment at the moment, in the absence of magic bullets, is to rest and to convalesce in the conventional sense. Gentle activity below the anaerobic threshold that I indicated in one of the previous slides is probably the gold standard in terms of the exercise you should take. And hopefully when we get ME/CFS centres properly set up in the UK, early referral for specialist management would be advisable. The other area of responsibility that I take as my own is informing employers and also schools, in the case of children, to be fully appraised of the nature of ME, and it's important to send them a decent statement to tell them what the problem is and how the child should be managed. So in summary, I'm going to have a go at the current NICE guidelines because they are basically not fit for purpose. And Mark Baker, the chairman of the GDG, which produced those guidelines, has actually said quite openly that they are currently not fit for purpose because they have such a psychiatric flavour to them, and they also tend to draw a lot of their advice from the culture which produced the PACE study. Now, most of you will know what an appalling disaster the PACE study has been, and how misleading the statements and the conclusions drawn by the authors of the PACE study have been for the medical profession generally. And a lot of patients have not done well as a result of the NICE guidelines, and in turn as a result of what the PACE study promulgated as appropriate quotes treatment. The scientific evidence now indicates organic disease, and that organic disease urgently requires further funding for proper research. My own informed speculation is I think there's something wrong with the mitochondria in these patients, and it may well turn out that mitochondrial disorder is at the basis of much of the symptomatology of this horrible condition. So that's where I'm going to finish, and I hope that you will regard what I've thrown at you this evening as pearls of wisdom rather than anything else. But I sincerely believe that ultimately, possibly within the next 2 or 3 years, we're going to see some answers as to the exact organic nature of this condition. I am old enough to have remembered the days when AIDS first hit the scene. And for about 4 years, patients with AIDS were subject to the same degree of skepticism and suspicion as to their lifestyle and why they were like they were, why they were diseased in the way they were. It was all to do with lifestyle, the gay lifestyle, and being drugged up and so on and so forth, until someone discovered a virus, and then the situation changed. Even then, with HIV, because of the initial skepticism and disbelief that a virus might be the cause, there were disasters in relation to blood transfusions and blood products being regarded as safe. And the result was that a lot of haemophiliacs were injected with HIV virus in the belief that these blood products were safe. We have the same position here, I think, with ME, and a lot of patients have suffered as a result of a lot of misunderstandings perpetuated by what I call the psychiatric paradigm. But I think now the tide is turning. Thank you very much.